I'd like to really thank Michael and the Infoway team for really pulling us together today. This is really quite an event, and we can see the full room and colleagues across the country. It's a real honor being here, and all of the sessions this morning were extremely inspiring. And what I'll hope to do in the next half hour or so is just try to add perhaps some examples, some perspective to, I think, a number of the themes that were already raised in a very powerful way earlier today. So the title of my session is Digital Health, Interoperability, and Clinicians, Shaken, Not Stirred. And at the end of the session, I'd like us to be able to define clinical interoperability, to recognize the need for early clinical engagement, and then to discuss two projects. One is an eNotes, a synoptic reporting initiative, and then the other is ConnectingGTA. And then for us collectively to consider some next steps in accelerating clinical interoperability. In terms of conflicts, I'm not aware of any perceived conflicts with the materials. I do, however, wish to gratefully state that in terms of the eNotes synoptic reporting project, we've had generous support from Canada Health Infoway and significant in-kind support from the Canadian Partnership Against Cancer. The Infoway support is not just financial. We've had frontline leadership from people like Terry, from Brent McGaw, and from Jennifer Zellner, just adding expertise and thought leadership, and we're grateful for that as well. And on ConnectingGTA, similarly, Canada Health Infoway and our colleagues from eHealth Ontario, who are also well represented here in the meeting. So thanks not only for the financial assistance, but for your collective contributions. I should, however, say that I'm holding Infoway responsible for having me consume 2 breakfasts this morning and a very generous lunch. And so I'm probably exceeding my caloric intake, and I haven't even gone to the social event this afternoon, okay? And I thought I'd just share a little bit about my breakfast this morning. So it was at home. It was around 6:30. I was facing 3 sleepy teenagers and an 11-year-old. And I asked them, I said, do you want to hear what interoperability, what I'm talking about today? And they're about as vocal as Glenn's surgeons. With no reservation, they said they had absolutely no interest. So I turned to the family dog, and she very affectionately came after me for scraps of food, but I don't think was too interested in interoperability. So I'm hoping that the Twitter feeds and all the feedback on this session will be a little bit more positive than I started this morning. So anyway, with that in mind, let's proceed. So the idea here about being shaken, and here I'm looking at it from a clinical perspective, I think most people in the room drive a car. You either own a car, or you've rented cars, or you do both. How many of you have actually taken a course in auto mechanics? How many of you read your driver's, your auto manual? Not a representative audience. So I think we got about 30%, but I think if you went to the general public, it wouldn't even be that high. So the point that I'm trying to make, and this is in line with some of Glenn's comments, is how much IT training should we expect clinicians to participate, endure, whichever sort of description you want, and think about the training requirements that we have before they can actually enter a hospital environment and use an electronic record system, or to use a voice recognition or a dictation system, or the number of different systems that they have to be approved on before they get in. And then when we raise the complexity of the fact that many of them are working in multiple organizations and may even have their own private practice, you can see how things end up compounding on us. The other one, and more on the industry and the development side, is how do we encourage and sustain health information technology communities and the sustainability around that, and how do we make this a marketplace where innovation is incented and rewarded appropriately? And I think we touched on that theme, and I know we have some terrific vendors here. They're representing not only their companies, but again, they're here as thought leaders and contributors to Canadian healthcare. So here's something that shakes me every day. This is an image taken right outside my office on a general surgical floor, 9 Eaton South at Toronto General. So many of you may be aware that UHN 10 years ago established international leadership in going live with medication order entry. This is an image of one of our hardworking nurses taking an electric blow dryer beside a sink to a wet chart, because we still have a hybrid environment. Much of our daily charting is done on paper. Some of the orders are still placed on paper, and that paper chart is still integral to the care process. I also wanted to sort of follow up on, and I think Brian was here and he declared very boldly some of his health-related issues. Well, yesterday evening, I was on a floor just 2 up from this one, and we were starting a newly diagnosed patient with inflammatory bowel disease on a biological agent. Like many of these drugs, we have to dose on a weight basis. And guess what? There was no weight in the electronic record. Couldn't find the weight in the paper record. We went asking, oh, you know, Nurse Betty took the weight and she's on break and it's probably in her pocket and all the rest of it. So the question, and going back to Glenn's theme, is why was that weight not in the electronic record? You know, we've gone out, we've mandated, we have a good section, it's quite readable, but look at the workflow. The nurse came on shift, had to go from room to room to room. We've got wows, we've got all kinds of hardware. Each one would require that person to log in, go in, put the weight, go through about 3 different screens to put that weight in there. That's why it's sitting on a piece of paper in their pocket while they're on break. So these are some of the challenges, and that's why we're still shaking. So I'd really like to thank Ryan and Glenn for setting me up on that comment. So it's not just us, and I can see, you know, Lydia Lee, who I could tell you is a wonderful CIO. Do not hold her personally responsible for that hybrid environment. We're all working together on this, and this slide tells us that we're not all alone at UHN, and we're not all alone in Ottawa, and we're not all alone in any of our major centers, because I think many of you are aware of the Canada EMR adoption model, and this is looking at hospitals and our HIMSS adoption level. As you can see, as of Q2 in this year, very few organizations in Canada are at stage 4 and above. Now, again, and I think this ties into Trevor's comment, we have to basically make a case for a need, and there is a need. And Glenn gave us a number of examples, Trevor also did, and that is by living in a stage 3 or below environment, we don't have those safety checks in there. We don't have the pathways that Glenn very nicely depicted in, you know, Joe's sort of model that he published. You know, the various forced sort of safety checks in there, the better continuity of care, the medication closed loop administration, the chronic disease management tools. We're not leveraging those aspects of the electronic health record in any sort of systematic way. Lots of pilots, lots of people doing very cool things, but not across the board and not as part of the standard of care across the country. Now, again, there are great examples, and you know, I just shared some, and Alan Barkin, if you don't mind, I'm going to single you out. There's a group at McGill that have taken advantage of clinicians using their own devices to message each other around patient care. Now, rather than, you know, hitting them with a stick and telling them not to do it, they've actually created a protected environment where it works. And so, Alan, I'll give a plug for your session later. Clinical working group, I'm sure you did something like this. Propose the functionality. A small interface team. I just heard a story. There are like 2 or 3 developers. They build a prototype. They have a working group that provides feedback, functionality, and off and away. And they have a system that works within their environment to help them deliver care and to protect some of the key sort of issues that I'll get into in a moment. So that's a little bit more on the clinical side. I'd say there's a lot to be said on the vendor and on the, you know, the technology side as well. And again, I'll pull out an example that we're quite proud of at UHN, and that is our systems engineering medical informatics group some time ago, under the leadership of James Agnew, our manager, put together an HL7 application programming interface, and they call it HAPPY. And you know, the principle behind this, and this is sort of testing my limits of technical knowledge, is that they wanted to be able to bring in Java developers into our environment that really didn't know all that much about HL7, you know, the kind of standards that Trevor was talking about. And they wanted them to be able to work and to, you know, tap into their talent. So they put up HAPPY, and they looked at different ways to sort of disseminate and improve it, and they decided on a free and open source access model. And as you can see, HAPI is now used across the globe, and we have people contributing, from leading private sector organizations, public sector organizations, industry, and it just gets better and better as we have more and more contributors to that. And it creates a more sustainable environment for the development community to come up with applications that scale and meet the needs of the healthcare environment. Now, many years ago, when I learned how to teach swimming, one of my teachers said two things. One was, a good teacher is a good thief, and repetition is good. So I'm going to take advantage of those two sort of principles. And here, I'll steal from Trevor with permission, and that is the definition. And that was one of our objectives, definition of clinical interoperability. So if you didn't catch it the first time, you'll catch it the second time today. And that's when we have systems and devices that can exchange and interpret shared data to assist clinicians. And just remember, he presented with nice little cartoon graphics the idea of the laboratory result going into the clinician's office. Now, for those of us that work in kind of the trenches of care, I think many of us find it a privilege to be able to work on the information's technology side, but then also to deliver care, because in a way it gives us the advantage and the disadvantage of dealing with both sides of the equation. Now, some of the key issues, and I think Glenn got into this in some detail, is ease of access. We need an acceptable response time. We have to have the required functionality, and you heard that from the Netcare group. If they only had half the province's lab results, guess what? Nice system, but not all that useful. If I have to wait for the fax machine, the mail, and go into Netcare, chances are I won't go into Netcare. Security and privacy requirements, getting back to Alan and the group at McGill, they took something that was not secure and probably violating, quite frankly, privacy requirements, and they brought it into a safe environment where it can be utilized appropriately. And the ability to support it on a long-term basis, and I think many of you are aware of terrific systems and software that come up, and it's great, and if it's not maintained properly, and if it doesn't have the upgrade and functionality, and once again, we heard that from Netcare, this is not we'll release the software and we're good for the next 10 years. They're continuing to improve it on a continuous basis. Again, Trevor, I won't dwell on this, but what I found very powerful in this message, and I thank someone like Trevor and his position at Infoway for embracing it, is to looking at interoperability as a user experience. That's a very, very powerful message, and I think that's why a lot of us are in the room here today. And I think I'm seeing Glenn is nodding. It's a very, very thoughtful and helpful statement as we move forward. So here are some news snippets. I know Glenn sort of pulled in a lot of the academic literature, which I think is very important, but this actually is also important, and this is taken from the Boston Globe just this past July. And I think it's a bit of a caution flag, and that is hazards tied to medical records rush. And as you can see in the sort of subheadline, subsidies given for computerizing, but no reported required when errors cause harm. Now, this is not a new concept. As Glenn indicated, the academic literature around CPOE and electronic sort of systems for healthcare date back at least 10 to 15 years, both on the positive and negative side. Koppel and others have published some very, very good data on a whole new breed of medical error that's strictly confined to implementing CPOE systems. So here's, another sort of look at that, and a bit of a caution. I think many of you may also have been made aware, this is the American Medical Association calling for design overhaul of electronic health records to improve usability. So to me, that means we're in the right place at the right time to, look at nationally leading organizations like Infoway, looking at the vendor community, looking at clinicians, looking at healthcare organizations to see how we can learn from these kind of experiences and how that we can provide better care and better systems in the Canadian and the international health system moving forward. So now, before I wrap, I'll just give you a couple of little case vignettes. So it's not just all about the theory, that we can see where there's some examples to move forward. And once again, I think many clinicians, we like the case study, we like showing that you can start with little things and spin them off into bigger things. And so let's take a look at a couple of examples. So the first one is our clinical support synoptic reporting initiative. eNotes is one of the names we've attached to it. And what this really is a project which has two dimensions to it. The first is we wanted to achieve national consensus with the development of pan-Canadian colonoscopy and colposcopy data models to support clinical best practice. The other was to develop and implement reporting templates in 3 Canadian jurisdictions using an open technical solutions approach. And then we wanted to establish a governance structure to maintain and disseminate these data models. And then we wanted to work with industry to develop and implement effective and affordable solutions. So a lot of this may not make a lot of sense right now, but hopefully it will after I get through the next couple of slides. So first of all, looking around the room, there are a lot of young people, but you know what? There are also some folks with a few gray hairs. So I'm assuming there may be some, and I'm not going to ask for a show of hands. I'm sure there are folks that have had a colonoscopy, or you know, some of our female members in the audience that have had a colposcopy, and there may be some really lucky people that have had both. And so the point is, the reason that, and I'm among those that have had colonoscopy. I've had a family history of colorectal cancer, so I've had a colonoscopy. So the point is that, you know, these are leading causes of Canadian mortality related to cancer. There are real issues around quality in these procedures. There are issues around who's performing them, how they're reporting them, how they're communicating them, all the rest of it. You see this in the media. There are also issues around who's appropriate to have access to care. There are also a lot of people that may have the first or second exam, and guess what? They fall off the grid and they're not recalled in an appropriate way. So there are people that are being over-investigated, under-investigated. There are good performers, bad performers. You lay on the Glenn Geiger metrics, no report cards, we don't know what's going on, and it's a bit of a mess. Okay, so the idea here was not to boil the ocean, but to heat it up 1 degree at a time, okay? And so the idea was around quality, communication, access, resource allocation. And what's a bit painful here is that there are national and international clinical best practice guidelines. They exist. We know what we should be doing, and we know how we should be doing it, but we don't do it because it's not implemented and it's not measured, right? So that is, I think, one of the sub-themes for the day. So in comes Infoway. I don't have a musical background to this, but they helped us with the funding. And in addition to Infoway, we aligned, as I mentioned, with CPAC. And I think, you know, very importantly, we aligned with organizations like the Canadian Association of Gastroenterology, Canadian Association of General Surgeons, and then with our colposcopy colleagues, the Society for Gynecologic Oncology and the Society for Canadian Colposcopists. So these are all expert groups that really don't know very much about IT, which is just fine. They probably shouldn't, but they're very, very focused on quality and delivering the best sort of care and disseminating that, you know, to their various members. Now, I think a number of you in the room may know a lot about synoptic reporting, but I'll just give you a very brief sort of cartoon tour, and that is that we generally start with a patient. We try to put a structured sort of documentation type of experience in front of the clinician, very much as Glenn said, around MedRec or discharge summary. Then we like to have that in synoptic coded clinical encounter data so that we can complete our clinical notes in a very timely and effective way. But it also provides data for us to look at patient outcomes, look at adherence to clinical pathways and guidelines, quite frankly, for some of the functions where you're aligning with best practice guidelines. And then I think very, very importantly, provide secondary use data for research, quality assessment. And really, when we're dealing with chronic disease and cancer, we're often dealing with timelines. Now, in the paper world, it's impossible to manage those kind of timelines. In the electronic world, we should be able to do it fairly effectively. So we created the data model, and that is through national consensus. We had some face-to-face meetings, and then quite frankly, most clinicians are really, really busy. Even if you offer them a paid trip and everything else, they're often too busy to take advantage of it. So we used telecom, web, we leveraged their existing meetings, so we reached out to them, and that's where those other organizations came in. And then we weren't, sort of just flying the Canadian flag. We tried to look at other jurisdictions where they've done a lot of key work here, and we collaborated with groups such as the CORI Initiative in the US and the Global Rating System in the UK. And then just a couple of snapshots. Now this is what it looks like within our UHN, sort of made-at-home clinical interface that we launched through our enterprise electronic patient record. And what we did here is we have a graphical annotation tool, and we have some various functions, and this generates the report. And I think at one of the tables over there, we have Tran, Mary, and Kelly. And when they're not as productive delivering human beings, they're delivering all of these really cool sort of applications. And we're very grateful to the sort of business and project expertise that we have in them and their colleagues, because they're able to get the feedback from the clinicians in all parts of that little design cycle that we sort of discussed a little bit earlier. Now, what's I think even more exciting, and I saw Jim Shave here in the audience, and Jim, I think kudos to you and your team at Cerner, because what they did is they worked with this data model and our colleagues at North York General and VHA to actually build the data model within Cerner. And so this is part of their Power Notes platform, and we're working with some of the other vendors in order to do that. So that, going back to Trevor's sort of message, is the strength of going agnostic when it comes to a technology perspective. And so that's what it looks like at North York General, where they've had very, very good adoption, and also at Island Health in BC. So literally across the country. Now this, I'm not sure how, I hope it projects. And Kelly, I thank you for presenting this data just very recently. And that is, as part of the work, we did a short survey around endoscopists. I'd like you to look at the blue and the red bars, and just as you go down there, you can see the vast majority of endoscopists felt that an electronic endoscopy system would adhere to quality standards. Now, where we need a little bit more work is, they also believe that it would make data available, to Glenn's point, for research and quality improvement. There was no doubt about that. Where we need to do a little bit more work is on the user interface, the ease of finding information, the challenges around productivity and not slowing people down in their workflow, the format and layout of the information. And remember, what we've done traditionally, and this is new breaking ground for us, is when we generate a lot of these technical notes, it's one size fits all. What we're looking at doing is creating one for the non-technical referring physician and also one for the patient that would reside in their PHR, a summary report. This is when your next study should be, and summarizing the key data elements. And that's where we need patients sort of working with us in that way. And then timely information, when they're completed electronically, as Glenn said, by the time the patient leaves the room, this thing is auto-faxed. I hate to say it, Glenn. I swear, I can't believe I'm talking about fax machines in, 2014? But, and I'm just looking for the day where I can throw that fax machine out my window, but I don't see it in the immediate future. But at least the notes are auto-faxed to the referring physicians right away. And for inpatients, by the time they hit the ward, the note's in the electronic patient record, versus a transcription turnaround of who knows, right? And then, now there was some discrepancy around where the information is collected is relevant. A lot of that actually comes down to some of the clinicians saying, oh, I don't want to use that standardized scale for whatever. And sometimes it's a bit of sometimes there's credibility, and other times it's, you know what, doc, you're behind the times. You've got to use this scale, because this is best practice. We want to know the anesthesia risk score on every patient that you're doing. And you could battle it all you want, but hey, you're not meeting best practice standards. So the lessons learned: never start with the technology. Establish clear and meaningful goal to improve outcomes in care. Design scalable interventions. We started with a few sites, and now we can scale this, and we're looking at national sort of perspective. Implement, evaluate, and iterate, which is what we continue to do. And this is not an area where you can be selfish. You really have to share and collaborate and look at what other jurisdictions are doing and bring it all together, and then build up a plan for sustainability. In our sustainability for the data model, we've given the ownership of the data model to the Canadian Association of Gastroenterology. In exchange, as best practices change and emerge, they will update that model through the Quality Committee. And likewise, the Society for Canadian Colposcopists will keep the colposcopy data model updated. And that gives credibility as we work with the health industry vendors, because it's not just a pet project out of wherever. This is at a national sort of society expert level that we're looking at these data models. So I'll move on to Connecting GTA, and again, I think a number of you may have heard about this, and once again, I give, credit, kudos to other, provincial and regional sort of groups that have tackled this. Here's our sort of version around Connecting GTA, and that is we're looking at 6 LHINs around the Greater Toronto Area, fairly small geographically, but we're looking at about half of Ontario's population here. So well into, I think we said, I think it's over 7 million. By the time we started, it was 6.75, but now I think we're over 7. That's how quickly it's growing. And what's most exciting is not just the numbers, but the fact that we're addressing all sectors of care. Acute, community, complex continuing, long-term, mental health, rehab, primary, the whole gamut, which I think is very, very important. Now, I think what's also, maybe not as exciting, but very important, is that we're taking, the Infoway blueprint approach here. And that is, it's very much based on the Heil architecture. And so we're not creating whole new clinical information systems, but we're pulling data from those clinical information systems along with various registries and other data, and we're making it available at the point of care. And so at the infrastructure perspective, we're drilling in everywhere from ultimately a primary care EMR through to any other clinical information system in the province, right? That's the architecture, and I think the strength of the model. And really, it has been driven by clinicians from the beginning. I won't go through every single point on the slide, but we identify and collect information, and that goes into a clinical data repository, provides us the opportunity to exchange the information through the Heil, and then through various means that I'll show you, clinicians can access that information within Connecting GTA. Now, clinicians have been involved from the very beginning, from the concept to designing the RFP, to selecting the vendor, to doing usability testing, and now in limited production release to giving feedback on that as well, and into the performance and the training of the system. So every step of the way. And so no big surprise, the priority data types that were identified and that we have right now, hospital reports, diagnostic imaging reports, lab results, and we're working with the ministry here in Ontario on drug information, likely into 2015. And we already have some community care access data, and that's just building along with timelines. Now the workflow aspect, and I think Alan discussed that a bit on the NetCare model, is we have single sign-on through the hospital clinical information systems or the participating organizations, where within patient context, they will be able to launch the portal. We also, through coming soon, the eHealth Ontario One ID portal, will be able to log directly into Connecting GTA. And what's beautiful about that is we've already leveraged that for our Ontario telemedicine. So in the very near future, we'll be able to access the regional electronic health record and our provincial telemedicine portal simultaneously, which is very, very exciting. And then you can access within other portals, and then where we're moving towards is direct integration, so that clinicians, rather than launching another portal, will be able to get the information directly within their EMR or their clinical information system. And that, again, is where we really have to reach out and work closely with the vendor community, otherwise that will not be possible. So this is what our design group has done, and some screenshots. Input right from the beginning. We worked with the vendor, worked with the team, worked with our funders, and it was really some very nice productive Scrum sessions, and we finalized the solution very much in an iterative way, and then we scaled it up. In Wave 1, we're looking at over 30,000 users. In Wave 2, we plan to go to 40,000, initially with about 20 health service provider organizations, and then up to 100. So that's what I mean about starting small and scaling up. And so certainly you can visit the Connecting GTA website. Lydia and I are both here. We can talk to you ad nauseum. You may want to visit the website and just sort of sort through. So I just wanted to really maybe go back, hopefully, just really thank the various members of our clinical working group, and particularly the co-chair, David Dan. He's the better looking guy on my left, who's a primary care doc and has done a lot of really key work here in the a provincial EMR space, along with the other members of the group, and there are a number that obviously aren't in the photo. And, you know, our groups back home at UHN, our Center for E-Health Innovation, our Techna Institute, and thanks to all of you for giving me a chance to highlight some of these. So thank you.